So first of all, I'd like to thank RSL Lifecare, especially Linda, for the opportunity to present to you. In the next 30 minutes, I would like to take you through the Molnlycke healthcare journey. Molnlycke healthcare traces its origin to a village of the same name in Sweden, is committed to being the vanguard of innovation and provider of better clinical solutions. The development of SafeTac technology in 1990 revolutionised wound care. Dressings with SafeTac technology reduce both pain and tissue damage in wound management, minimising pain and trauma. To the patient, this means less pain during dressing changes, less trauma to the wound, means reducing tissue damage and skin stripping, allowing the acceleration of wound healing. Molnlycke healthcare arrived in Australia in 2003. SafeTac technology was embraced as the gold standard for patients with fragile skin, and the implementations of best practice with the introduction of skin tear guidelines at major public hospitals, Royal North Shore being the very first hospital to implement the skin tear guidelines using Mepitel and Mepilex Border. Mepitel was the first SafeTac dressing developed in the world and has been used on over 100 million wounds. Your own RSL Lifecare skin tear guideline was developed in 2012 with your clinicians using Mepitel 1. It began with Mepitel, and now the new Mepitel 1 is on the skin tear guideline. The last 4 years has been about PIP, pressure injury prevention, and it still is. It's a very relevant topic, as you heard Matt speak this morning. So once again, the compelling evidence from worldwide clinicians and Australian Professor Nick Santamaria from Royal Melbourne Hospital has evolved into the introduction of Mepilex Border Sacrum and Mepilex Heal as best practice as part of the solutions of pressure injury prevention in hospitals and in aged care facilities. In the layers of healthcare, we at Molnlycke enjoy the position that we occupy, that of bringing new concepts and products supported by clinical evidence. Almost as important as clinical evidence is our proof and our reliable support. Most of you know us by now. We've had a relationship with RSL Lifecare for 3 years now. Molnlycke Healthcare in 2016 is committed to aged care, with a vitalised aged care focus to bring you education, support and resources that we are so well known for in the hospital sector across the aged care, and we are delighted to be working with you. So my presentation from the slides which I have is really an overview of SafeTac technology, what that is and what does that actually mean to you, the clinician, and again just going over the clinical evidence that supports our dressings such as Mepilex Border Sacrum and Mepilex Heal, and also touching on some of the new products that have been added. So essentially we need to look at the past to see where we are now and where we're going into the future. So, see if I can work this mouse. Okay, so Molnlycke Healthcare is a global organisation, and it's the fastest growing wound care company in the world. I'd like to introduce you to Thomas Farbo, and I was so scared I was going to say Sabo because of my daughter's love of his jewellery. But Thomas Farbo was the inventor of SafeTac. He was a concept development manager for Molnlycke Healthcare. He spent 5 weeks in hospitals observing dressing changes, and what he uncovered was that the pain and suffering that the patients experienced during these dressing changes. So he really had one goal, and that was to try and correct that, and he invented SafeTac. So SafeTac was invented to bring one thing, SafeTac was invented to do one thing, and that was to take unnecessary suffering out of wound care. So what is SafeTac technology? What is so unique about SafeTac technology? It is our point of difference, and you've heard us talk about it so many times. So SafeTac technology is about less stripping of the wound, less wound adherence, and less wound maceration when managing in the management of wounds. So what that means is less pain to the patient and less trauma to the wound. So how does SafeTac technology actually works? Now, I think I need to click on this. No? It's not going to work for me. Try again. Okay, so traditional adhesives, they sit on top of the skin, where a SafeTac technology dressing is nice and soft and gentle, so it adheres to the skin surface, and therefore it is on a larger area, and there is less peel force when the dressing is removed. So that's one of the first things that you will notice about using a SafeTac dressing, is that it's very gentle when you remove the dressing. So I'm just going to show you the stripping and how it compares to traditional adhesives. So with a traditional adhesive, okay, it's working over here, but it's not working on my screen. So you can see that when you're removing a traditional adhesive, there is the potential of removing the epithelial cells that have just formed on that wound. But with a SafeTac dressing, that minimises that happening because of the gentleness of the dressing itself. A study that was done, and I know it's 2001, but it's still a goodie. What they did was they dyed the patient's skin with green dye and placed different dressings. And so what this shows that the Molnlycke border doesn't cause skin stripping. Okay, so you can see that the Molnlycke border is still quite evident, while the other dressings have caused skin stripping. Minimising maceration. So a traditional adhesive tends to sit on the wound, and I'll see if I can get that. Yes, it's working. And a SafeTac dressing seals the edges of the wound. So what it actually does is move the exudate up into the secondary dressing and away from the peri-wound. So that although that sometimes we're told that SafeTac is sticky, we like to use the word tacky, but that exactly plays a part and a role in wound management because it seals the edges of the wound and forces the exudate up into the secondary dressing and away from the peri-wound. Okay, so why choose a SafeTac dressing? Because it damages less, it's less painful, faster healing, which of course all leads to lower costs, so that we know that the reduced number of dressing changes and the wound that will heal faster will also reduce that cost. So pain at dressing changes does matter, and this was a survey of 2,000 patients in 2008, where they asked the patients, what is it like to live with a chronic wound? Over 40% said that dressing changes were very painful and it was the worst part of living with a wound, more fearful than an amputation. So it's also very well documented that pain causes stress and anxiety, which also increases or delays wound healing, so that these play a role in delaying wound healing in the management of wounds. And it's well documented that this is the case, that patients are anxious and they're not looking forward to having their dressing changes, and it does cause some physiological effects that causes stress and in return delay wound healing. As someone said, some people are fearful of going to the dentist. Can you imagine having to go to the dentist every day or every second day? What that would be like. Okay, so Professor Upton has done a lot of studies in this area, and again, it's proven that pain does delay wound healing. Now, this is the skin tear. Start again. This is the skin tear guideline for RSL Life Care, and it was put together by your clinicians. It's not a Molnlycke guideline. It is your guideline. I know that the clinicians are very proud of it because it's very straightforward and clear on what the management is. And what these guidelines do is just means that everybody can manage skin tears in the same way. So therefore, patient outcomes are much more improved. With this guideline, you have Mepitel 1, so that the guideline is using Mepitel 1 on all those categories of skin tears. Mepitel and Mepitel 1, some of you may know that Mepitel 1 is probably a few years old now, but Mepitel is over 20 years old. So the difference being is that the SafeTac silicone was on both sides of Mepitel, but with Mepitel 1 it's only on one side, which makes it a lot easier to handle. The pores are larger, so the exudate can move through the dressing much quicker, and it's also more like a film, so it's a very transparent dressing and easy to use. And it can stay on for up to 14 days. So that's the key message with Mepitel, and it's exactly the same with Mepitel 1. So essentially what is happening is that you have undisturbed wound healing, and the dressing is protecting the skin and creating a moist wound healing environment. And you change the secondary dressing as needed. We often hear nurses that still want to check that wound on a daily basis, so this is the way to do it. That you can change the secondary dressing, have a look at the wound, irrigate over the top of the dressing and leave it intact so that you've got undisturbed wound healing underneath. Molnlycke Molnlycke is Australia's #1 foam. So it's been around for a long time, and it is an alternative to Mepitel. It's all about the layers with Molnlycke. Has 5 layers, a layer of SafeTac, a layer of foam, a spreading layer that will spread the exudate so that it doesn't pool in one area, and then the exudate is housed at the top of the dressing. And you know how we say to you, leave the dressing on for up to 7 days? Well, you can do that because the exudate is in the top layers of the dressing and away from the wound bed. It also has a polyurethane film which makes the dressing shower-proof. And we know that if you use Molnlycke on a skin tear, that we encourage you to draw an arrow so that you know which way to remove the dressing. So Molnlycke has been very successful. Began on the New South Wales contract, I think now 8 years ago, and it has continued to stay on the New South Wales contract. So it obviously is a very good reason why that's happening. Okay, so this is a pressure injury prevention guideline, and we're seeing a lot more of these in hospitals, throughout most hospitals. I look after Sydney South West, and 2 years ago they implemented a pressure injury prevention guideline for patients at risk of developing a pressure injury. And what this does, it follows the evidence, and it follows the regime that was found in those clinical papers of peeling the dressing back daily, checking the skin, and reapplying the dressing. Why this dressing? What's so special about this dressing? First of all, it's the evidence. So yes, I'll go back. Why this dressing? Okay, so again, we talk about the layers. Professor Nick Santamaria, the construction, said that the construction of the dressing played a very important role, so that with moisture, shear and friction, and this is what we're talking about. We're not talking about pressure. We're talking about dealing with moisture, shear and friction, and the new buzzword of dealing with microclimate on the skin. So that what actually happens, that when a patient is in bed, they tend to be, they perspire, so any moisture will be taken up into the foam part of the dressing, and each time the patient is moved up and down, it's the top 3 layers of the dressing that is moving, and not the skin, which is protected by the SafeTac layer. So clinical evidence, we've been talking about this for about 4 years or 5 years now. Todd Brindle was the very first clinician in the US to hypothesize of what would happen if a Molnlycke sacrum was placed on a patient at high risk of developing a pressure injury. These dressings were initially developed to manage a pressure injury. The results were so great, as the young ones say, that it actually went viral. And there were so many copycat trials throughout the world, all finding the same thing, that it actually does reduce pressure injury rates. But again, it's important to point out we're talking about moisture, shear and friction, and it's only part of the solution. It's not the total solution. You still have to put your patients on mattresses, you still have to turn them. So this is only part of the solution dealing with moisture, shear and friction. There was a consensus statement that was put out where key clinicians all agreed that the Molnlycke border sacrum and the Molnlycke heel all played a very important part in pressure injury prevention. This is only a part of the evidence. So if you're really interested, you can Google to your heart's content. There is a lot of evidence there. And we have been talking about this for some time, but it wasn't until Standard 8 came into play that clinicians began to look around to see what they could do to address this issue. And in my territory, I have Sydney Local Health District that are about to implement this product, and also Sydney Southwest that have had this for 2 years now. And it has made a huge difference to the pressure injury rates. Okay, so Professor Nick Santamaria is the Australian guru for pressure injury prevention, and he has written quite a few papers, also one paper looking at the cost of pressure injuries. I'm always very interested to hear when nurses say, but the dressing is very expensive. Yes, it is expensive, but as we heard this morning, that a pressure injury costs $60,000 to heal or to manage a pressure injury. And I've heard Professor Nick Santamaria say that when his nursing executives say to him, you're costing us too much money, he just says that I'm moving it from your management budget into your prevention budget. So eventually that will come down. And the findings of his paper were so significant, both the heel and the sacrum, that it has really been taken up and noticed. And in fact, Professor Nick Santamaria right now is doing a pilot study in aged care with both these dressings. So it'll be very interesting to see what the outcome of that is. It's a national study, and I believe that he has 35 aged care facilities enrolled. So watch this space. He said that he's going to get it right before he has to go into an aged care facility. Okay, so I did mention Molnlycke heel because that is also part of the equation. During his trial, he also found that the heel reached statistical significance a lot earlier than Molnlycke border sacrum or the sacrum, so that heels are just as important as sacrums when we're looking at pressure injury prevention and management. Okay, so this is the selection. We have gone from Mepitel over 20 years ago to quite a few dressings now on the Molnlycke range. So what we've been able to do at RSL Life Care is show them how we can reduce all these dressings into core dressings, so that, for instance, perhaps 7 or 8 dressings that can be used on a daily basis to try and cut costs. Most facilities will have 15 to 20 different dressings that the nurses can choose from. So this is what we've been able to do, working with clinicians at not just RSL Life Care, but other aged care facilities as well, to show them how we can introduce the Molnlycke range of products and be cost effective at the same time. Molnlycke AG. This was a favourite, and it's been introduced 5 years ago, I think now. And initially it got a little bit of a reputation as a gentle dressing. Yes, because of SafeTac, it was very gentle, and the pain aspect of it was much better, that patients did say that it was less painful. But in recent times, there's been a lot of evidence supporting this dressing as an antimicrobial, and there's evidence to show that it has some very good results in healing times and also against biofilms. So watch this space. So the antimicrobial range has grown from just Molnlycke AG to Molnlycke Border AG, and the new Molnlycke Transfer AG, which in your booklets, is a booklet in your satchels that has these 3 products that I'm just about to talk about, so that you have those in your satchel. So if you need any more information, please contact us. Molnlycke XT is, I was going to say the same as Molnlycke. It's not the same as Molnlycke. The pores are larger, so that it will actually absorb thicker and sluffy exudate, and that's the difference between Molnlycke and Molnlycke XT. Exuviber is a new gelling dressing. It's very exciting. It's made of PVA fibres, and I was speaking to a vascular surgeon recently, and he said that they make stents out of this material. So I guess that's where the strength comes from. So it's a gelling dressing that you can remove in one piece, and it doesn't leave any fragments in the wound. Molnlycke Transfer AG, it's a contact layer, but it's also an antimicrobial. So the dressing can stay on for up to 7 days, although we do know that it will continue to deliver silver over a period of 14 days. So the concept is that you change the secondary dressing and you leave the Molnlycke Transfer on the wound. And we've had clinicians that have used this on leg ulcers with great, great results. Okay, aged care. This lady is going to appear on all our new aged care material, because we do understand that in aged care there's specific information that has to be presented in a different way. So it's not acceptable to use all of our hospital education, marketing and resources material. So with this new initiative in aged care, that there will be a whole set of new resources specifically developed for aged care. So I'm transitioning into the aged care market, if you like, and I'm the New South Wales representative now for aged care. So as I transition from my current territory into aged care, it's very exciting. We have a national team, and they've called us the MAC team, Molnlycke Aged Care Team. So I have a little quote that Sheila wanted me to add, so I will. I'll just get to it. Okay, where are we? Okay, so you always do what the boss tells you to do. So it says, our promise to you is to continue to support you, so in turn you can provide better outcomes for your patients. So this is the New South Wales Wound Care team, and I think most of you would know Julie and Julia, and Bev and Susie and myself and Rosa and Loretta. But so as we continue to grow the aged care team, they will continue to work in their local aged care facilities. But I guess I'll just be overseeing aged care in New South Wales as the team grows. There's only one person at this stage in every state, but the initiative is there to continue to grow this team and provide you with a better service. Thank you.